Hey, I appreciate it. Thanks. And thanks for having me. Thank you for Pearl for having me and Catapult for organizing it and having me. And we have a lot to go over tonight. I'm super excited to be here. And as you just said, we may as well get going because I think there's a lot of information. The title is one that I use often, and I believe in it quite profoundly. Every case is a big case. There's a lot of things that make every case a big case. And one of those is treatment planning, the way you treatment plan, which helps change your confidence and competence and flow in your office. And when you think about um, treatment planning, some people ask often, well, how does occlusion fit into it? And some people, especially since 2008, which I've been a big part of, how does Airway fit into it? Or especially these days, how does it all come together in the digital world? And finally, geez, how is it all related? So tonight, I want to try and encompass all of this, and again, hopefully a little less than an hour, and talk about what is it. And when we think about it as far as every case being a big case, it might be having a better understanding and flow for things that in the analog world were a pain in the butt, but the digital world might make them easier, but really only if you know what you were doing in the analog world for the most part. And every case is a big case because if we can have a better understanding of what's going on with the chewing system, and again, especially in the digital world, we as dentists are seeing things differently to help communicate differently with our patients and allowing us to help our patients move towards optimal health in a way that's appropriate for them. And in the end, really, my what I believe to be true for probably everybody on this call, and probably every dentist and probably every dental team member, is we just don't like surprises. We want everything to be more predictable. And so for me, every case is a big case in the sense that how can we actually be more predictable? How can we have less surprises? And that means you see the four words I use there. Um, can we be more comprehensive? Well, that word gets abused on a regular basis. What does that look like? We'll look at that tonight. Patient-centered, meaning what really is going on with the patient, and we're going to incorporate that tonight. Health-centered, are we looking at everything that's contributing to what's going on with our patient? And finally, the bottom one is really important, which is occlusion-driven. Occlusion is a primary reason that things become less predictable, and a lack of understanding of occlusion is where our anxiety seems to go up. So we're going to dive deep into that tonight. As we start, though, with this sense of predictability and every case is a big case, I'm going to ask you to make one assumption with me tonight. And the assumption is, and I think it's a safe assumption, that everyone wants to be healthy. Now, can you make that assumption with me and in the best interest of everybody we work with? You can, and I will tell you why. Because you see this sort of spattering of books here. If you look on most people's bedstands, uh, bedside tables, you will probably see what they're really wanting to feel, and that is they want to feel healthy. Most people are reading, how can I be a better version of myself? How can I feel better? How can I be more healthy? If you were to actually look at everybody's phone and look at what podcasts everybody's actually listening to, or what TED Talks people are watching, or YouTube videos, it's amazing that you will see most people want to be a better version of themselves. In fact, again, can we make an assumption that everybody wants to be optimally healthy? It's just that nobody has had a conversation with them about what that looks like and how they can take steps to move in that direction towards optimal health. So I'm going to ask you tonight if you can embrace that and just make an assumption. Everybody wants to be healthy. They do. It's just nobody's had the conversation about what that looks like for that patient and how they can move in that direction. We will use Diana tonight specifically with the limitation of our time, and again, no matter who walks in your door, It could be Diana or anybody else. I'm going to start with an assumption that she wants to be optimally healthy. She just doesn't know what it looks like, and nobody's had a conversation with her. But she comes in with some concerns. In fact, she was quite upset that she's had a little filling break off of number 15, her upper left second molar. She has had a class 4 composite on number 8 for years that's been replaced 4 times. By the way, she's only in her early 30s. She doesn't like the feeling or the look of her lower incisors. She doesn't like the discoloration and the notches on the gum line on the bottom. And even so, I'm going to make an assumption she just doesn't want the class 4 not to break, or she doesn't just want that filling replaced. I'm going to make an assumption that she wants to be optimally healthy, which means that we've got to take what's going on with her and her life. So on the left, we actually have to then do a thorough examination. That's the clinical findings. And as you see on the right, we actually have to have a way to envision what optimal is for her. And when we combine all three of those very intentionally, which is what we're doing tonight, I would say that we are actually helping our patients move towards optimal health in a way that is appropriate for them. Now, I have a bias. I'm bringing to you some of my history and what is my influences, right? What has influenced this? And I think it's only fair that you know what has influenced. So I graduated in 1995. Very shortly after, when I realized dentistry is harder than I thought it was going to be, I started going up to Seattle and started learning from Frank Spear in Seattle. In the early 2000s, I knew there was more, and so luckily these influences go well together. So what I learned from Frank, I went down to the Pankey Institute in the early 2000s for a few years and went through that curriculum. So I'm influenced by that as well. As I started getting into education a little bit, and I won't bore you with that story at the expense of time tonight, I started. I realized and I got asked that maybe I could start sharing that early in dentists' lives, even at the dental school. So I was working at the dental school while having a practice in Portland, in Oregon. And long story short, I ended up being asked in the middle of 2013 if by the beginning of 2014 I would actually move from Portland, Oregon, rainy Portland, Oregon, to beautiful, sunny Scottsdale, Arizona to teach full time at Spear Education. So again, where I have taught treatment planning and occlusion and airway and team-centered systems, this is all part of who I am. My disclaimer for tonight is that since 2018, I have a business of my own where I work with practices across the country, integrating what we're going to talk about tonight, and more, of course, looking at the business side, et cetera. So I do have my own business, again, working with dentists across the country, and I do still teach a few times a year at Pankey, so still a big part of my life. So, knowing all of that, my influences and what's going on in my life, let's move back to it and the assumption that everybody wants to be optimally healthy. So, if Diana comes in and we can start with an assumption that she wants to be healthy, then we can actually assess her current status. Now, her current status includes who she is as a human being, what her core values are, what her current temperament and circumstances and objectives are. So we do take the time to intentionally get to know her as a human being. We call that the preclinical examination. But again, what are her temperament, circumstances, and objectives so that I can flex towards her as a human being and gain her trust so I can help her move towards health. I also have to assess her current status of her chewing system. And I say chewing system very intentionally because I am going to, and tonight I don't want to sound judgy, but it maybe challenge you a little bit, maybe some small shifts in helping you think, am I looking at my patient's actual chewing system? Am I looking at their current status of the joints, muscles, teeth, and periodontium and the way they come together? The gift of that is, if we are looking at the whole chewing system and understand the chewing system, our confidence and competence definitely goes up. Our anxiety goes down. We can connect with the patient more intentionally. And then we can treatment plan. So when we assess joints, muscles, teeth, and periodontium in your 0150 comp exam, one of the fun things about this, that, and I really believe it's fun, is we actually start to do our exam with more intention because as we treatment plan tonight, and we're going to go deep into this, when we treatment plan, we're actually going to always treatment plan in this order: aesthetics, function, structure, biology, and airway. Now, of course, there's more to it with the words you see on the right, but in general, no matter what the patient walks in for, we're going to treatment plan optimal in this way every time, starting with the tooth position in the face, looking at occlusion, looking at the condition of the teeth, what's optimal structure, do we have the biology, the gums and bone to support the structure, and is airway or breathing involved? Because if it is involved and we haven't identified that, the predictability goes down for all of the above categories. So as we start doing the exam, we're like, oh, I actually need this information for treatment planning so I can actually have a conversation that is a little bit more fun for everybody in the room. Well, when you think about the examination, your examination, one that grabs people's attention because they're not so comfortable with it really is the functional part of the examination, including the joints, right? And so, again, tonight is not a big presentation on the joints, but my hope is that you actually, by the time you're done with the examination, you have a best guess as to what you think is going on underneath the skin. Yes, with respect to the disc, is there a little piece popping off or not? Is that what the sound is coming from? Is there any obvious inflammation in there? And you can do that just by feeling and watching and listening and have a best guess as to what is going on underneath the skin. Now, again, we can go over the head of the condyle, the glenoid fossa, the articular disc that's held in by a ligament in the back, and the lateral pterygoid muscle in the front, and that has some retrodiscal tissue all behind it. But in general, it's just nice to know that yes, this is a joint where the ball actually is made to come out of the socket. A disc actually travels with it. And when the disc isn't in place, there's some things that happen, and we might be squishing on that retrodiscal tissue. But in general, this is the only joint in your body that the ball is made to come out of the socket when you open, and when you close, in my opinion, which is what I've learned, the ball is supposed to go back into the socket. So an understanding of what is going on with the joint is always important. So I'd be remiss if I didn't at least show these two slides tonight, demonstrating that if we just barely start to open, we call that rotating. But when we open big, we translate. What you see with that red dot there is the pressure on the joint. It starts in the medial pole and moves to the lateral pole on the brain side and moves to the outside. Why is this the one thing I want to bring to your attention tonight? Because if the only we get so scared of joint noises sometimes, and when we actually realize that, oh, really what it is sometimes is that there's a teeny tiny piece of the disc off, as you see there. And sometimes it pops a little bit more because that pressure we just mentioned that moves from the medial pole to the lateral pole actually is right at the lateral pole when that teeny tiny piece of the disc is trying to pop on. So it's really not so scary. The disc is still there. It's a teeny tiny piece that pops off. It's part of the human body. And it's really just the pressure gradient moving from the medial pole to the lateral pole that's causing some popping. Good to know, but I would like to have a good understanding of that. Now, I am very biased about Pearl AI, and one of the things I'm excited about is that they have FDA clearance to start looking at our CBCTs, which is going to help all of us feel more confident and competent with what's going on with the whole chewing system, including the glenoid fossa and the head of the condyle and the rest of the workings of the joint and the mandible, etc. So I'm really excited for this part of Pearl AI. What right now Pearl isn't going to help us with, because it's really not their wheelhouse, it's not radiology or anything else, is an understanding of what is going on with the muscles. Why do we do an examination of the muscles? Well, it's pretty straightforward because your muscles are going to be sore or big when we go to the gym, right? Well, this patient here is going to the gym on a regular basis. The exercise they're doing is moving their jaw back and forth, side to side, grinding their teeth together. And what do you think is going to happen to the muscles? Well, they're going to get big, they're going to get sore, they might even be different from one side to the other. So it's important that we examine the muscles because it gives us an idea of how often our patient is going to the gym, what exercises they're doing at the gym, and how that might be contributing to why their teeth look like their teeth and why we're having to restore their teeth. And speaking of restoring teeth, the other reason that we might be restoring teeth is the way they're rubbing against each other. So during the examination, we could ask our patient to grind to one side as far as you can go, grind to the other side as far as you can go, and we could actually ask them what teeth they feel touching, knowing that certain teeth should touch when you go side to side and front to back, and even edge to edge. And we could put some tape in there and actually assess what teeth are touching when you bite together, tap tap nice and hard, and when you move side to side, which teeth are touching and rubbing against each other, and maybe that's why that mesiolingual cusp on that lower second molar broke off. And we don't always have to put tape in. We literally can just ask our patients as a starting place, when you bite together, do you feel front teeth more than back teeth more than front teeth, left side more than right, right more than front? What do you feel when you move to one side? Is it back teeth touching? Is it front teeth touching? So just start to assess initially how the entire system is going. So we look at the joints, we look at the muscles, we look at the teeth and the periodontium. What's going on with the joint? Are the muscles working against each other in harmony? Are you going to the gym on a regular basis? The condition of the teeth and the periodontium. And finally, how are the teeth actually rubbing on each other and how might that be contributing? So in my opinion, that is assessing the status of the current chewing system. And we can do that with intention. It doesn't have to be completely thorough, although of course I'm biased. I think it could be, but at least we're looking at the whole system. Again, one of my favorite things about Pearl AI is we are starting to get more help with our confidence about what's going on with the chewing system. It's pointing out some um, some what do I want to say? It is pointing out some processes that maybe we would have separated, and it's bringing them all together for us to look at the whole chewing system a little bit better. And of course, when we talk about 3D, you want to talk about really for us and for our team starting to see the chewing system a little bit better. When something like Pearl AI starts to understand a pano, which it is right now, and pointing out so many different things on a pano, our confidence and competence goes up quite a bit. So now we can understand the chewing system and start to get an idea of how healthy is it and what do we need to do to move towards optimal health. So when you think about, this is my challenge for you right now, when you think about putting words to an optimal chewing system with respect to the joints, muscles, teeth, and periodontium, can you put words to it? For instance, my hope is that when you open real big or move your jaw forward, that the ball comes out of the socket like it's supposed to, with the disc in place. And when you move back together, that the ball goes back in the socket where it belongs with the disc. And as you're moving your jaw, opening and closing and side to side, that the muscles on the left side are working in harmony with the right side to bring the ball back into the socket and to bring your lower jaw up to your top jaw so that all of your teeth touch evenly and simultaneously. And when you move your jaw in any direction, your front teeth make your back teeth come apart because that's their job to protect the back teeth, and that the gums and bone that hold your teeth in are disease free and solid so that your teeth don't wobble. If that's the case, we can now start to put words to an optimal chewing system with respect to the joints, the muscles, the teeth, the way the teeth function, and the periodontium. And if we can put words to that, we can help our patients move in that direction. And we actually know the direction we're moving into because I know most dentists, and I'm not bashing the world of dentists, most dentists coming out of dental school can't put words to an optimal chewing system. So if they can't do that, how can they help a patient move in that direction? And it's really fun when you think about it, and I really mean fun, because a suboptimal chewing system, which is probably everybody on this call and everybody's going to listen to it, probably is not optimal, which means your body is always doing what? Well, you see it right there on the screen. It's adapting. You have a threshold of adaptability, which means your body is doing a good job adapting until it's not. And when you move beyond your adaptive capacity, that's what I would say is your danger zone, meaning we're starting to see signs or symptoms that allow us to have a conversation about how your body might have be moving beyond its adaptive capacity. So, for instance, right in the middle of the zone of adaptability, it would be perfect. Well, that's an optimal chewing system, which we just described. Anything less than that means your body is compensating, but it's still doing okay. As we move through life or our body starts doing crazy exercises like grinding, can't sleep well, it's already a suboptimal system that's trying to accommodate, it'll start to break down. Now, if your patient is right here, still within the zone of adaptability, my challenge for you is why can't we have a conversation now about moving back into the middle of the zone adaptability as opposed to waiting until there are signs and symptoms telling us you've moved beyond your zone of adaptability, and now it's going to take more work to get back to the middle. So, for instance, what you see here on the right is probably everybody on this call. It is the chewing system. It is your body accommodating for a suboptimal chewing system. The ball doesn't go right back in the socket. It's trying to find the most comfortable place for your teeth to touch, which means the muscles are always trying to work to have them hold there, and it's doing a pretty good job until it's not. What you see on the left is when the patient bites together, the ball goes back in the socket. All the teeth touch evenly and simultaneously, and the muscles aren't having to brace the system to hold it there. So, why do we have to wait till so many things break down to have a conversation about moving from the right side of this screen to the left side of this screen? Well, how do we figure out how much, for lack of a better, how not how bad you are or how broken down your system is, but we can start to look at how much your body is compensating, how much it's accommodating so that we can have that conversation. Well, for me, one of the best ways to understand that is we take a bite record in what we call a fully seated condylar position, or you can call it centric relation. I don't care what you call it, because when we take a bite in a fully seated condylar position, if the ball is in the socket, how many teeth should be touching? I'll let you think about that for a second. If the ball is in the socket where it belongs and you bite together, how many teeth should be touching? Well, all of them, because that's an optimal chewing system. So, how can we real quickly figure out how much the body's compensating? Well, you can use a really simple tool, a leaf gauge. And what a leaf gauge does is it allows you to keep the back teeth apart so the body doesn't feel like it needs to compensate. You can slide your jaw forward, pull the ball out of the socket, and then back to allow the ball to seat in the socket. And the lateral pterygoid will deprogram after a while. So as we slide forward and back and squeeze, the ball's going in the socket until we take out enough leaves eventually that you feel a tooth, the patient feels a tooth touch with the ball in the socket. And if it's not all of the teeth, then guess what you just determined with the patient? That their body is compensating or accommodating. And we get to see how much it's compensating or accommodating real closely because we can, again, use a leaf gauge or a lucia jig to keep the back teeth apart, as you see here, to get the ball into the socket. And again, once we've got the ball in the socket with no teeth touching, because you don't need teeth touching at this point, we just need the ball in the socket, you can now take some silicone or wax or whatever you want in between the teeth, and the patient now can bite into that with the ball in the socket. Now you've got a bite record of a fully seated condylar position. What can you do with that? You can mount that on either an analog or digital articulator. And what we're going to see here is take the wax out. As you bite together, there's a tooth that touches, and then the body slides forward to get as many teeth to touch as possible, as comfortably as possible. You just got to see how much the chewing system is accommodating to get as many teeth to touch as possible, as comfortably as possible. That fully seated condylar position bite record I've been doing this since about 2014, middle of 2014 in the digital world. Now lots of people are doing it, which is great. It's making it easier. Those blue dots you see are the teeth that touch in a fully seated condylar position. And with different software these days, whether it's exocad, 3Shape, etc., what you are seeing right here and the patient can see and feel is moving from centric relation or a fully seated conular position into their acquired bite, right? Or maximum intercuspation. You can see how much the body is accommodating every time the patient bites together, and they don't even know it until they do. Hopefully, not until, hopefully, they don't notice it when something finally breaks, which is usually the case. So, for us, if we don't wait till something breaks, we can actually have a really realistic replication of the patient on an articulator, again, whether digital or analog, looking at the teeth that touch with the ball in the socket. And what you see on the right are some printed analog models, and those blue dots represent the teeth that touch with the ball in the socket. Well, it's not all of them, which means the patient is doing what? You got it, accommodating every time they bite together. So why not help our patient move towards optimal health in a way that's appropriate for them? So now that we understand the current status of what's going on, we can look at the three things that can impact the reason it's not optimal, or the three things that are going to impact predictability as we try and move them towards optimal. And those three things are the way you breathe and sleep connected, what you put in your body, how it's affecting your systemic health, and of course, what you put in your body, how acidic is it, how hard is it, etc. And then the bottom one is, how are you living in 2026? How are you managing health and wellness? Because that's also impacting your teeth. And if we look at those three things very intentionally, it's going to help us then move towards helping our patient move towards optimal health. But we do have to assess those three things. Now, tonight, we don't have time to look at those three things, but I'll tell you, if we are looking at those three things and how it's currently impacting the system, and again, how it might impact the lack of predictability if we don't assess those three things and probably address them, which means we have a possibility now to restore our patient to optimal health. Well, how do we do that? Well, let's move quickly here because there are so many people, so, not so, yeah, so many people and so many organizations that have beautiful um, systematic approaches to treatment planning. I still teach Bill Robbins' Global Diagnosis. I'm a big fan of the way John Kois teaches up in Washington, and it's very similar to the way we are teaching it at Pankey, to the way they're teaching it at Spear Education, to a lot of to the Dawson Academy, right? So for me, it's Pankey, Spear, Kois, Dawson, really are really my influences. So my goal is to bring those all together and make it as simple as possible for you. So what is optimal? Well, we just said that the ball comes out of the socket, but the muscles bring the ball back in the socket where it belongs, and we have all the teeth touching evenly and simultaneously. But where do they touch? Well, I would like them all touching cusp tip to landing area, not on any inclined planes. And I also like the back teeth touching just slightly harder than front teeth because that's their job. They're the squeezers and the front teeth are the guiders. And when you move your jaw in any direction, your front teeth make your back teeth come apart, but in a very smooth, shallow manner so that they don't beat each other up. Because these are your protectors. So some people call it cuspid rise, canine guidance. If you want to really change your practice, start to refer to the front teeth as the protectors. Because if they're not in the right place in the head to do the job they're supposed to do, or they're rotated in a funny way, or they're wearing down, they're about to not be able to protect the back teeth the way they're supposed to. That to me is an optimal chewing system. So let's apply that to Diana then, because no matter what she walks in for, we want to have a systematic way to treatment plan optimal so we can have the conversation. Well, again, as we said, it does start with the front teeth. And let's walk through this so that you can apply this literally tomorrow. Because we said we're going to go down these in order: aesthetics, function, structure, biology, and airway. Well, aesthetics is not really about aesthetics, is it? For today, it's about edge position. So let's start with aesthetics and edge position. We're going to use photos very intentionally, including the one you see on the far left-hand side, a profile photo. My favorite is the second from the left, the profile photo with a smile. which helps us determine are the teeth in the right place in the head, anterior, posteriorly. Yeah, I call this a poor person's lateral ceph, by the way. If you don't have a lateral ceph, you right now get to determine is she maxillary deficient? Are her teeth too proclined or retroclined? Are they about in the right place in the head to do the job that they're supposed to do, which is to protect the back teeth? So now we're going to use some photos intentionally. We're going to use the lip at rest. Some might say Emma, lip in repose, lip at rest, to determine where the teeth should be in the head, not to look good, but to do the job they're supposed to do, which is to protect the back teeth. So for somebody in her early 30s who doesn't have, um, uh, who does not, whose maxilla is in the right place, right? So does not have any maxillary deficiency, we would probably, if we look at the literature, we'd say, 2 to 3 millimeters is a good starting place. Now, there's some nuances that we won't get into tonight, but if this is all you do right now, start to think about, use lip at rest. What is the age appropriate amount of tooth structure that should be showing with lip at rest for male and female? That's your starting place. You start with the centrals. And then again, we think, well, the cuspids, the cusp tips of the cuspids should be at about the same level. And then the laterals just sort of fill in, make things look good, don't they? And so we start with the centrals and the cuspids with the lip at rest, and the laterals just fill it in. Now we use the smile photo to say, all right, if we added, that half a millimeter, a millimeter, 2 millimeters, whatever it is, do the incisal edges still follow the contour of the lower lip? This is your check and balance, right? To make sure that the teeth are in the right place in the head to do the job they're supposed to do, which is to protect the back teeth. And then you can move this back if you want to help you start to see what optimal is for where the teeth should be in the head to do the job they're supposed to do, all the way back to premolars and molars if you want. For me, a key point, and you don't need DSD, you don't need Smile Cloud, you don't need Keynote, you don't need PowerPoint, you can draw. If we just have a photo and now we outline the existing teeth with a pen or a pencil, imagine this is a piece of paper. You outline the existing teeth, and then the next step is, well, based on the photos, I now know where I want my optimal incisal edge based on the lip at rest photo and the smile photo. And this is really critical. If you get nothing else out of tonight, we start with incisal edge position. Why? Because it's where the teeth belong in the head to do the job they're supposed to do. Now that we know where we want the incisal edge, step 5 is look at the proper height to width ratio. Now what you're seeing, I see the 5 didn't show up on the right. Now what you see is the difference between where she is and what optimal looks like. Not for aesthetics, but to have the teeth in the right place in the head. And when they are, by the way, of course, they look good. That is a byproduct of teeth that function well, is they're going to look good. How nice. And now we're starting to get an idea of treatment planning. And then you start to see, are, for lack of better words right now, does the free gingival margin really matter? Because you can start to see the optimal tooth position and length and width ratio. And is the lip showing it or not showing it, depending on the length of the lip, mobility of the lip, etc. We'll do the same on the bottom teeth. All we have to do is pick where we want the lower incisors, based on where they are on the face, or you can go back to old dentures, right? 2/3 up the retromolar pad, level lower plane of occlusion. But what you have at this very point is a visualization of where you want the edges of the front 12 teeth, top 6 and bottom 6, to do the job they're supposed to do, which is to protect the back teeth. Once you have that, now we get to function. Trust this process for me, because you now can start to put the function in where it needs to be and test it. And starting with the anterior teeth, I call this the outside in approach. What do I mean? Well, if I've got Diana's models, and these are her models, both will go analog and digital, but in the analog world, I've got her models mounted in that fully seated condylar position so I can see how much her body is compensating. What is the first thing I'm going to look at? Well, those are the teeth that touch in a fully seated condylar position. They're not all of them, so we know her body is compensating. With those models, the first thing I'm going to do is put the edges where they belong. Now, again, we'll talk about this in the digital world, so hold tight, but let's know what we would do in the analog world first, which is Put those edges of those top six teeth where they belong in the head to do the job they're supposed to do. And then move down and do the same on the bottom. Maybe add, as you see here, a little wax on 27, smooth off 23 and 26, add a little wax to 24 and 25. Now you've got the edges where they belong in her head optimally. This also, one of the things I love to share with you, and I only will briefly tonight, is this is actually helps you determine the vertical dimension of occlusion. If you've got the front 12 teeth where they belong in your head and close the articulator, that is, in a perfect world, the simplest way to determine what is the vertical dimension of occlusion and whether you need to open it or not, or close it, actually. So now that we've got the front 12 teeth where they belong, now we move them. Move it to one side, cuspid rise all the way past cuspid rise to what we call crossover, and make sure the back teeth aren't touching. Move to the other side, cuspid rise all the way past cuspid rise to crossover and end to end. Now you are checking, are those front teeth doing the job they're supposed to do? Now I said, and make sure back teeth aren't touching. Well, sometimes back teeth are touching, and we would call those interferences. So if in fact back teeth are still touching, the front teeth are where they belong in the head to do the job they're supposed to do. So what you need to do now, the way I train in this and coach this is you get rid of where the back teeth are touching. Isn't that really helping you decide what the shape of the back teeth need to be so that the front teeth can do the job that they're supposed to do? So we get rid quickly at the same time of balancing interferences. Well, now you get rid of those balancing interferences, and now you want to talk about smooth flow of the front teeth. Cuspid rise to crossover, silky smooth. Cuspid rise to crossover, baby butt smooth on the other way, and end to end. Because the front teeth are in the head doing the job they're supposed to do, and now back teeth are not touching when you go in all these excursive movements. Now, real quickly, yes, if you know what you're going to do in the analog world, it's sort of the same in the digital world. Put the top six teeth where they belong in the head based on your photos. Put the bottom six teeth where they belong in the head based on your photos. And on a virtual articulator, whether you're in ExoCAD, 3Shape, etc., we get to see, are they functioning smooth, and are there any back teeth touching that we need to get out of the way? You can do this in the digital world, but you need to know what you were going to do in the analog world first. And once we've got the front teeth doing the job they're supposed to do, it really is the easy part. Now, of course, it takes some knowledge and understanding of how to do it, but now all you need to do is have the ball in the socket and get all the back teeth touching evenly and simultaneously, forces directed down the long axis, which is cusp tip to flat landing area, so that now the whole chewing system does not have to compensate. You are now about to create an optimal chewing system. If we just look ahead of time to see what teeth are in about the right, I call this planning your stops. Which cusp tips are already close to touching a flat landing area, whether it's a fossa or a marginal ridge or a transverse ridge on an upper first molar? If you look ahead of time, then you start to realize, oh, I need to move this buccal cusp to the distal a little bit, or I need to raise this landing area just a little bit. So as we get the front teeth where they belong, get rid of the balancing interferences, if you know what cusp tips need to move or shift a little bit, we can actually see the work we could do to just recontour teeth. Literally, minimally, what is the best we can do by just recontouring teeth? It may not be optimal, but as you'll see in a couple minutes, it is a way to start to phase treatment in. And what a gift that is for affordability and for our comfort zone for treatment, as opposed to having to prep a lot of teeth at one time. So this step is really critical because now I can see what I might be able to do on the first appointment to help her move towards optimal health in a way that's appropriate for her. However, as we start recontouring teeth, you realize, oh, some of these teeth are just pretty beat up. I can't make all the teeth touch evenly and simultaneously. So now you move to the ones that can't touch or you can't recontour. We take little globs of wax, and imagine this in the digital world now, and put the cusp tips where they need to go so that they can touch the landing areas that are flat, like a marginal ridge or a fossa or a transverse ridge. It's not rocket science. You start to see here, I'm building up landing areas, I'm putting cusp tips where they belong. This is a quadrant that you see here of back teeth that are all touching evenly and simultaneously, cusp tip to flat landing area. And don't forget, the front teeth are discluding those in a smooth, shallow manner because that's what we started with. So in the end, what you see here is a blueprint of what optimal is for Diana. And you're saying to yourself, that is the ugliest blueprint I've ever seen in my life. I can't disagree with you. But I have an understanding of where I want all the cusp tips and landing areas and where I want all the edges of the front teeth. And if you don't like the way that looks, you can either send that to the lab and say, make it look good for me, or don't forget, if we're going through all of this in the digital world, trusting this process of you see on the top left-hand corner, putting the front teeth where they belong, bottom left-hand corner, the bottom front teeth where they belong, top right-hand corner, finding out what teeth they touch, and the bottom right-hand corner, getting rid of the areas that touch, getting rid of the balancing interferences. In the digital world, the teeth already look great, and you can do anything you want to start to phase it in in so many different ways. I would be remiss if tonight I didn't bring up just for a couple of slides, literally, what could you be doing while you're treatment planning optimal? It's one of my favorite topics. It's a whole different presentation lecture. What could you be doing is allowing the patient to experience optimal. We can build an appliance, whether printed or acrylic. These days, there's so many options, but the appliance is built so that all the teeth touch evenly and simultaneously with the ball in the socket and the front teeth making the back teeth come apart to protect them. Your patient could be experiencing optimal while you are creating a blueprint of optimal, and that's going to change the conversation for everybody. Now, if the patient's experiencing it and you are creating it, let's finish creating that real quickly here. So you've done aesthetics and function. Now you get to structure. Why is this so important? Because you, on the right-hand photos, you see where the patient started. On the two left-hand photos, you've got a vision and a couple different ways of what optimal is. Well, now you can look at literally every tooth and say, can I just recontour it for optimal? Oftentimes that is the answer. Yes. So the structure is whatever it is. Enamel, if it's an old crown that you can recontour, you don't need to redo that tooth. The second option is, oh, it looks like a whole new tooth in a whole different space sometimes. So now I see where I need to reposition it for optimal function. And then maybe I get to leave the structure exactly what it is. What a gift. Or is it so beat up already that I actually need to reposition it and it still needs to be restored? Or do I just need to restore it? Or is it so beat up that I need to remove it and then I am going to actually replace it and pick the structure you're going to replace it with? And sometimes you actually get through this treatment planning process and you get to have the sixth R, which is my favorite. You realize you actually get to revitarone. It had to be an R, right? Because there's six R's. Revitarone meaning that tooth is in the right place in the head, doing the job it's supposed to do, and I don't need to do anything to it. If you go through this process with every tooth, you now just came up with a treatment plan of what is optimal for this patient. And sometimes there's some questions involved. So if we do the first couple, aesthetics and function, and we're trying to determine structure, sometimes this is when we need some people who are smarter than we are to state the obvious. And that is, hey, here's this blueprint I've created. I think I'd like this to be an implant, or I think I'd like this to be a crown, but I'm running into some problems here. So we sit down with our specialist with our blueprint. Well, imagine sitting down with our specialist and using something like Pearl AI, where we now have a better understanding of the structure, what's going on with the structure. We're seeing things differently and communicating differently because AI is changing our world in dentistry right now. It is one of my favorite things about Pearl that it changes our conversation, including the last topic for treat. Well, we'll get to Airway just briefly, but the last part is biology. So why do we do it in this order? Because my question now is, do I have the biology, the foundation, for the structure that is optimal? For the function that we found out was optimal, that all started with putting the front teeth in the right place in the head to do the job they're supposed to do to protect the back teeth. Well, biology really is, I now need to know, do I have the biology to reposition it? If I need crown lengthening, do I have the bone and the soft tissue there? If I'm going to remove it, do I have the bone to replace it? So, for instance, if we think about Diana, I'd say to my periodontist, I think I know what my blueprint is, but do we need to graft this? Do you want my glass ionomer in there first or not? Or I say, excuse me, to my endodontist, I'm about to redo these crowns on the premolars and these root canals look crazy. Do you need to redo the root canals? Well, imagine adding something like Pearl to this, where it's going to start to point some things out for you. Do you have a radiolucency at the apex? Do you have what kind of bone loss do you have there? What is the crown to root ratio? It's going to start to point these things out. Well, it is not going to start to. It's already pointing these things out so easily for us to change the conversation with our patients and with our specialists. So imagine sitting down with Pearl and all the work we've done and saying, do I have the biology endodontist, oral surgeon and periodontist? Do we have the bone that we need there for the restoration or the implant, et cetera? So you can see how Pearl is really helping the treatment planning process and communication for our patients and for us. And finally, as I mentioned earlier, we get to Airway. If Airway is a part of this, if it's not addressed, it is going to reduce the predictability of everything above that. So now that we know what optimal is, now it's time to have some fun. We now get to have conversations with our patients that we didn't used to be able to have, which is, I know, and this is what's critical right now. What I know to be true, Mrs. Jones, is that form follows function. And what I'm worried about, or the concern I have about your chewing system, and again, this is a presentation in and of itself, verbiage around this, but I want you to start to think about how your confidence and competence with these conversations with the patients changes immediately because you know what optimal is, you know what's contributing to it, you know that form follows function. And so we get to say, here is your current condition. I have this vision of optimal. Here is what I think would be in your best interest, or here's what I think would be the appropriate next step for you. What are you thinking about that? And then you heard me just use the word. Now we get to take the appropriate step to help our patient move towards optimal health. So let's go through that with Diana. For me, it is almost, nothing's always, of course. It is what can I do first to get those front teeth doing the job that they're supposed to do, which is to protect the back teeth? Well, because we went through that whole treatment planning process, I can now put composite, my material of choice, on the bottom lower and on the bottom lower incisors. They would, as opposed to the top lower incisors, the lower incisors is composite for me. I thought that was appropriate for her. And then I could do a trial smile for the top teeth and say, yep, they are in the right place in the head to do the job they're supposed to do. What you see right now is 12 front teeth that are in the right place to do the job they're supposed to do. So let's make it happen, right? So you can use the trial smile to sort of test your hypothesis, and then you can use the trial smile for appropriate depth cuts. And again, this is not a restorative prepping presentation tonight. Again, that's another presentation if you want, but we can use the mock-up to get proper depth cuts so that we are prepping as conservatively as possible for what's appropriate for Diana. And now you see that from the left was our treatment plan based on photos. The middle was a trial smile. The right-hand side is before we make them all pretty, is the edges where they belong. Well, what can you do now that you've got the edges where they belong on the top and the bottom? Exactly as we did on the articulator. I can move cuspid rise to crossover. That's clunky. Cuspid rise to crossover, a little smoother, and end to end. Well, what am I seeing? I'm seeing all those interferences that I saw in the articulator that I'm now going to move. I know my limitations to creating optimal for her today, which is I'm going to get as many cuss tips and flat landing areas as I can with her teeth the way they are. I would have never been able to have this treatment this predictable if I did not see it on the articulator, because this is a great finishing place for day one, isn't it? Her front 12 teeth, as you see on the right-hand side, are in the right place to do the job they're supposed to do, and we've gotten rid of all the balancing interferences and recontoured the teeth as much as we can. So now we could actually, for Diana, we could finish, her top six teeth were lithium disilicate and they were veneers. And now you put them in and they look great. And all the back teeth are now protected. So we can come in and just do the back teeth. They're in the right place. So I can come in anytime, one tooth at a time, two teeth at a time, a quadrant at a time, and start prepping teeth with intention now because I know where I want the cusp tips and landing areas. And my provisionals can actually test drive that cusp tips and landing areas. I can come do the other side way later. She can be in provisionals for forever. In this case, I went to the other side and notice the preparations can be really conservative now. You don't need full crowns. We can start doing different onlays when it's appropriate. And again, now I've got cusp tips and landing areas where they belong, at least on the top, but the bottom teeth are still the sort of beat up, broken down teeth. Well, that's okay because I can come in and seat, as you see here on the bottom left. Let's go through these. On the bottom left, all of the top teeth are done with proper cusp tips and landing areas because I knew where they wanted. Now I can come in and start prepping the bottom teeth, and we know exactly how we want the bottom teeth to look, where we want the cusp tips and landing areas to match the top teeth. So in the end, we now have cuspid rise to cross over. This is in provisionals. Front teeth are protecting those beautifully and smoothly. Let's go to the other side. Cuspid rise to cross over, silky smooth, and end to end. Man, now it's easy because we knew where we wanted the cusp tips and landing areas. We come in and design these bottom teeth. We're not winging it. We knew exactly where we wanted that cusp tip. We knew exactly how far distal or mesial to hit the landing area on top. There are no surprises. And if you want to go back old school, which I still love, when we go ahead and use a putty to create our provisionals, we have the cusp tips and landing areas there. So whether it's digital or analog, things become quite predictable right now. So as we now come in and seat the lower restorations, this is just initial try-in. Notice the left-hand side of your screen, the far left, which would be her lower right side, just the initial try-in. Just look at tooth number 30 right now and 29. Cusp tips and landing areas are there, but it's dentistry. They're just a smidge high. So it's easy. We start to make adjustments now, and you start to see all these cusp tips and landing areas just dropping in, and you do your adjustments with so much more confidence and competence because you know they're there waiting for you, and the front teeth are protecting those. So in the end, when she bites together, bam, all the back teeth touch evenly and simultaneously, cusp tip to flat landing area. She moves to one side, cuspid rise to crossover, silky smooth, protecting the back teeth. The other side, cuspid rise to crossover, baby butt smooth, protecting the back teeth, and end to end, a great place to hang out and protect the back teeth. So there should be no surprise at how it looks with lip at rest and beautiful smile with them following her lower lip. And sure, by default, they look good, but they look good because they're functioning well. And of course, she could always leave with an appliance so that what she's feeling during the day is the same thing she feels during the night. It's an optimal chewing system, whether it's an upper appliance or a lower appliance or an upper appliance here. So what you see is we've trusted the process, aesthetics, function, structure, biology, airway. We've done it quite quickly. I get that. I would be remiss if I didn't say a couple things. In fact, I think I've done this for Pearl before as well, a whole presentation on how to integrate this in your practice because you cannot do this without your team. You will struggle to do it without team-centered systems and intentional systems around what optimal looks like in your office. Yes, I'm abusing the word optimal, but it's because it's accurate. How do you want to feel in your office? How do we create systems to create this in your office? And how do we involve the team in this process? It is one of my other favorite categories. And speaking of team, as we finish up, you want to talk about supporting your team. Yes, I'm biased for a lot of reasons about Pearl. I mean, a lot of reasons. I may happen to be married to one of the reasons. However, I am biased. Think about how your team's confidence and competence is going to go up, for instance, with image check that they have. It's early 26, it's coming right now. It's not telling them how much they suck when they took the radiographs. It's, hey, did you notice these couple of things? Did you notice a little overlap here? Did you notice there's no root tips visible? Things that we miss, it's helping us. It's not grading us. It's not calling us out. It's helping us with predictability, and our confidence and competence will go up. In fact, nobody needs to see this except the team member that took the radiograph. And they're like, oh, yeah, thanks, Pearl. I didn't notice that. I didn't catch that. And think about my favorite thing about AI, and especially Pearl's AI, is how it's integrating with the practice, with your practice management software. probably like every PMS these days it's integrating with either natively or not. And it's going in there and it's looking at your practice management software and it's saying a lot of different things. It's actually doing a chart review for you. It's looking at what's going on in your practice and pointing things out, which actually can be brought up in your morning huddle. It's actually got a little morning huddle system about it in AI. It's like, you know what? You guys don't need to work that hard. You've got AI on your team right now. Why do you need to work that hard? Let Pearl work for you. In fact, I got to tell you, I like Pearl more for what's working. Sorry, Pearl. I love everything radiologic. I'm excited about the 3D. For me, it's how it's helping run a practice more because AI is AI. It's helping everything in the practice run more smoothly because the way it's integrating with your practice management software. So think about all the things it can do for you in your practice. And I think dentistry is only getting easier thanks to AI. And everything we've talked about tonight, as far as treatment planning, talking to your patients, helping them see the value in it is getting easier because of AI and Pearl. And we are at exactly 7:26, almost like we are 7:26 my time. 26 minutes after the hour. And first, I want to thank you for hanging out. I know that was a lot, but I wanted you to see the big picture and see how you can do it in your practice to increase your confidence and competence and your predictability. I am always here to help. One of my give backs to dentistry is looking at practices, looking at your numbers, helping you come up with goals. If there's anything you think I can help you with your practice, whether it's intentional coaching and consulting, just looking at your numbers, maybe just bouncing some things off, seeing if we could work together. You got my information. Pearl's got my information. Catapult has my information. Please don't hesitate to reach out. This is why I get out of bed every day, is to help people like you. And that is a lot of breath. And I'm going to pause right here. In fact, I think I'll actually stop share